tonight, like, in a number of settings, given a behavior talk, talking about the differences in being a behavior modifier. You should be a Coke machine and not a slot machine. Because a Coke machine, you put a buck in, you should get a Coke. If you put a buck in, you don't get a Coke, it's very unlikely you're going to put another $1 in. And if you do, because you're really thirsty or you really like Coke, chances are almost zero that you're going to put a third $1 in if you don't get a Coke the first 2 times. But any of us who visited a casino know that you don't stop after the second quarter or the third or the fourth or the 10th or the 20th. And it's because a slot machine is inconsistent with the payoffs. So you know you might have to be a little persistent to get the payoff. If you act like a slot machine and pay off randomly, it's going to take a lot longer to suppress the behavior you're trying to suppress than if you're a Coke machine. And sorry, insufficient funds, insufficient funds, insufficient funds, insert coin, insert coin. So that's kind of another principle. And to make the messages as simple and clear and even as brief as you possibly can. I always tell folks that when you start to get into a long diatribe and discourse with somebody whose behavior you're trying to modify, actually the message that you're sending to them is, this is still up for discussion. Whereas if you've seen some folks when they say no, but, point A, point B, point C, no. But really, you have to listen, blah, 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 no. And they realize, okay, this isn't changing at all. I'm getting absolutely nowhere. Everything I try, I get a 2-word, 1-syllable answer. So I guess it's time to quit because this isn't going anywhere. So little things like that. Okay. And we're getting about halfway through. So the last thing I'll say, and it's kind of like, I guess, circling back to the thing I said at the very beginning, is that I am sure there's nobody on this call who could say that your routines have not been completely thrown up in the air, spun around in the ceiling fan, and scattered everywhere, that it's absolutely not the life we had even 2 months ago. And again, under the best of circumstances, folks are struggling with that. And when you've had maybe a tenuous routine to begin with, trying to manage situations, I can only imagine that this didn't help at all. So I imagine that y'all are dealing with some pretty serious situations. On top of just our routines being disrupted, I'm just thinking out loud as to what must be going on with all these little boxes on the screen and all the little lives I'm looking at on the screen. And that another thing is that we're not allowed to be around each other unless we all live in the same house. So I would imagine for a lot of you, you have support systems that aren't allowed to walk through the door or that you have to stay 6 feet away from. And whether that support comes in terms of the tag team of tagging off, to help with actual support, to just a hug, to tell you things are going to be okay, babysitters, friends, schools, teachers, all of those folks, that we don't have access to any of that right now. Unless we violate some kind of quarantine, and then you're at risk of getting sick and all that. So acknowledge that your routines are messed up and your support systems are probably severely fragmented. That said, I would encourage everybody that I speak often when I give talks about the perils of idle time and idle minds. We know the old saying about the idle mind being the devil's workshop. In my career as a psychologist across multiple settings, whether it's working with caregivers, folks with brain injuries, athletes, other professionals, you name it, there are few evils in this world worse than idle minds and lots of unstructured time. It can lead to all kinds of problems, internal and external. On the internal side, anxiety, depression, other kinds of psychological symptoms. Externally, behavioral problems, bad habits. There's, of course, if you're on Facebook or follow any kinds of things like this, sort of the running joke with all of this is, delivery margaritas and all kinds of things, which again is funny, and it's a coping mechanism, and it could actually be a pretty effective one. But at the same time, taken to an extreme, that's a habit that, obviously we know is a pretty slippery slope. So Substance abuse, both for, the patients or the person with the injury and caregivers, can be a problem. So I guess what I would encourage more than anything is to do your best to establish some kind of routine. We all do so much better with structure. It almost doesn't matter what it is. It doesn't have to be saving the world. I've kind of encouraged seeing what not only is there a run on margaritas, on takeout margaritas, but there's also been a serious run on things like jigsaw puzzles. And I think that is absolutely awesome. On the positive note of our neighborhood Facebook page, it's turned into a makeshift jigsaw puzzle exchange where people are handing them off, back and forth. And my gosh, it's analog, so you're not in front of a screen all the time. The family's got to sit together to work on the jigsaw puzzle and communicate and all that. So it's awesome. So it could be, establishing jigsaw puzzle time, or something like that. Just that there's a predictable routine from 1 minute to one day to the next, that we kind of know what's going on, and you have something to do rather than sitting around saying, gosh, what do I do? Because again, you leave those minds idle, and it's not bound to end well. So yes, I will stop there, and I'll be happy to answer any questions anyone has. So if you want to type in a question, I'll do my best to answer it.
Dr. Temple?
Yes.
Hi, this is Pam Shipley. I'm on just the phone. I'm not on my computer.
Okay.
I have a question for you. I would love to know your... I'm sorry?
I didn't hear you. I'm sorry, go ahead. I didn't say anything.
You can hear me? Okay. I would love to know your thoughts on ABA therapy and CBT therapy, cognitive behavioral therapy, for a kiddo that has cerebral palsy, nonverbal, and recently diagnosed with autism.
Okay. So I think everyone heard the question, but I think the question is about applied behavioral analysis and cognitive behavioral therapy for a child with cerebral palsy. And did you say nonverbal?
Yes.
Yeah. That's an excellent question. I tend to be very behaviorally oriented. And so I'm definitely going to be in favor of that. I think that behavior and reinforcement and things like that are at the heart of just about everything. It's what we do. Like I said before, all of our behavior is purposeful, directed towards some kind of action. And we tend to repeat the things that are reinforced, and we stop doing the things that are either not reinforced or punished in some way. So I'm almost at a loss to think of a situation where those kinds of things aren't effective. Now, you named two different kinds of interventions there, behavioral modification or applied behavioral analysis, which is excellent. It's probably the strictest form of behavior treatment because it's not willy-nilly. It really just looks at all the antecedents to behavior, the behaviors, the consequences, things like that. And so the trick often is finding somebody who's trained in that and that you can afford, because it's a pretty time-intensive and probably by extension expensive kind of treatment. Mm-hmm. So if you can find somebody who does it, I think it's absolutely worthwhile, and it would be very well suited to your situation. As far as cognitive behavioral therapy, it's really the same thing, although cognitive behavioral therapy, the cognitive part of that is really more talking related. So I think maybe in your situation, more of a behavioral approach would probably be the best way to go.
So ABA?
Yes.
Okay. And then my next question would be, do you have any groups or practices that you would recommend? And would they do like a televisit situation, or how would that work?
I don't provide that service myself, and I'm not sure right off the top of my head who does. I could probably do a search And yeah, that now is the trick because it's hard to go anywhere in person.
Mm-hmm.
I think, any group that would maybe serve individuals with autism would be a good place to look and start because ABA is a big part of autism treatment.
Sure. Okay.
Okay.
Okay. Thank
All right.
you.
Then looking down the list, another question here, and I'm going to have to ask for clarification. Student Joseph Adam, would behavior modification be something like PCIT? If you could clarify what PCIT is, I'm not sure exactly what that is. So I'm gonna put that one on hold. I'm gonna move down to the next one. The next question is, how do you discuss anoxic brain injury with schools when they automatically think of traumatic brain injury? Regarding similarities and differences. That's an excellent question. So in terms of the definitions, a traumatic brain injury is some sort of physical force exerted on the head, whether it's your head hitting something hitting your head, or your head just being shook so violently that your brain rattles around in your skull and causes damage. Whereas an anoxic brain injury, by definition, this is probably what you already know, is your brain being damaged because of a lack of oxygen. In terms of similarities and differences, I guess as I'm thinking out loud right now, I'm wondering if there's a meaningful, there's a saying in brain injury, as there is in some of the other things, if you've seen one brain injury, you've seen one brain injury. I've seen anoxic brain injuries where folks are completely amnestic. I have lost their memory completely. I've seen behavioral manifestations, so on and so forth. And I've seen the same with the traumatic brain injuries. So my approach always, regardless of whether it's a stroke, a traumatic injury, an anoxic injury, is to assume nothing. Because until you've met with the person, talked to them, evaluated them, you really know nothing. And to assume anything is at your own peril, because you're probably going to be wrong more often than you're not. So I would say that, you really got to get down to the level of the specific areas of injury and how the person's presenting. That said, say this is a tongue-in-cheek joke, but you can line 5 people up and give them the exact same brain injury, to a scientific level of certainty. And I guarantee you're going to get 5 different outcomes just because of the way we're all wired and put together differently, that you can't assume anything by the MRI or the mechanism of injury or anything. So you really have to get down to the level of the person and really start from scratch each time. Okay, so I hope that answered. Next, can you explain exactly what I'm going to jump back down to? Okay, parent-child, the PCIT, parent-child interaction therapy. To be honest with you, I am not familiar with that modality of treatment. I could take some guesses as to what it is, if it is just kind of what it sounds like. I think that could be very effective because you could have a kind of a sense where each other is coming from, and maybe a behavioral. Okay, so we're talking play therapy. There's some literature on play therapy. I guess, it would sort of depend on the situation. With the population that I work with, we don't do it a whole lot. When I've seen it used, I think the problem has been I have not seen it used in a systematic way that really, is sort of evidence-based and scientifically based. So I think if it starts with a theory, then I think it has a chance. If not, I usually just kind of revert back to behavioral therapy as kind of my preference. Okay, next question. Can you explain what sundowning is? My son screams, throws things, hits in the evening, pretty much every night at around 6 p.m. How do you address this to make it better? Yeah, that's a difficult problem. I don't think sundowning is a unitary concept. Sort of in general, when folks are talking about sundowning, what they're talking about is towards the end of the day that there is a sort of a decline in cognitive status, whether it's a decline in behavior or arousal or different things like that that can happen. That can happen for a variety of reasons. To be perfectly, even though I'm a psychologist and I don't own a prescription pad, if it were my kid or it was my situation, my first level of intervention would be to talk to a physician, preferably a psychiatrist, to see if there's something that can be done in a medication manner to keep that from happening. When it's happening at the same time every day, it seems to me like there might be something going on metabolically or at a more medical level that could be changing that. So that would be my first line of intervention. And then if it's still going on after all of those things have been exhausted, then again, sound like a broken record, get back down to kind of the behavior side of things and see if we could figure out if there's some antecedents to the behavior that's going on. Again, it's very likely that it might be happening regardless of what's going on, in which case I would revert back to sort of the medical medication side of things. Okay. Any other questions?
Maybe we've answered all the questions.
Oh, we've solved all the world's problems.
Yes. Oh, yes. Wouldn't it be nice? Is there anything else that you can think of that you haven't said that maybe might? Oh, there's a question.
Severe anxiety and fear a part of brain injury? Absolutely could be. Again, given that our brain is the locus of everything that happens, that yes, it absolutely can be. And the question was just qualified. Is severe anxiety and fear a part of a brain injury for the child? Yes, you can trace anxiety, fear, anger, depression, all of those things, sometimes to very specific locations in our brains. So at the root of it, at the heart of it, could be severe anxiety that could manifest in any number of ways. Again, there's people who that when they get nervous and anxious, they cower and crumble and cry. I could tell you for myself that when I become anxious and sometimes even afraid, it could manifest in anger. It's like I get, it's just however it comes out. So yes, absolutely. And that could happen in a number of ways. I was thinking back to the talk that I gave a few years ago for Team Luke, Hope for Minds, that, any emotion, whether it's anxiety, depression, anything like that, can be one of two or a combination of those two things. It can be biologically based, and it's that the actual part of the brain that's injured that could produce that emotion, or it can be the stress of the situation where it's not necessarily that area of the brain that's damaged. It's more that the frustration that comes with the situation that's producing those emotions. So it could happen either way. But at the end of the day, I guess in the short answer to your question, yes, it's definitely the brain injury. Okay. So another question, would it be helpful to get somebody in that situation into a CBT therapist or be treated with medication? I'm going to answer that question with a single word, yes. If it's possible, the research for decades across almost every problem has shown that a combination of medication and therapy is more effective than either of those things alone. So I would, if you have the resources to do it, to hit that from both fronts. And specifically regarding your question about cognitive behavioral therapy, if someone who is practicing, strictly speaking, cognitive behavioral therapy, that is empirically a validated treatment for a number of different things, many, many different things. It's one of the more effective treatments that we have. is that, again, sometimes it's difficult finding good providers, but the more extent you can do some research and even call them up and talk to them and say, okay, everybody says they do CBT. Do you really do CBT? Were you specifically trained in CBT in some sort of a protocol that you take, that you do with people? If they say, nah, I just use cognitive techniques. If you can find someone who does better than that, I would say find somebody who does better than that, because it's a very rigorous program. The CBT that's actually been demonstrated to be effective in all of these randomized trials and things like that. But unfortunately, a lot of people say that they do things that they only kind of do. Okay. Okay, another question. Prior to my son's injury, he was very social and outgoing, and now he is exactly the opposite. Other personality changes have also occurred. In your experience, is this something that will eventually change, or is this a lasting change? So I think the best way to answer that would be that if left unaddressed, it very likely could become a permanent change. It's probably the result, if it's an actual personality change and it seems to be sort of at a deep level that you really feel like you're dealing with a different person than was there the day before the injury, then it's probably a fairly durable change. That said, again, I've been doing brain injury rehab for a very long time. I believe dearly in the principles of neuroplasticity, that nothing is permanent forever short of your life being gone away entirely. That it might take some work, some therapy, a lot of effort, but I think it's almost always possible to change to some extent. But yeah, if you're talking about that seems like a pretty lasting personality change that seems to persist over lots and lots of circumstances, it's probably going to be pretty durable and it would require some pretty significant intervention in order to be reversed. So the floor is open if there's any additional questions.
I have a question.
Sure.
Once you establish a routine and get that down, and the anxiety, you can see that it does lessen. So when you try to implement specific, like, I'm just wondering, because I know sometimes with brain injury they struggle with brain fatigue and also confusion and also memory. So they don't remember what they did, or they're confused, or like if they're not supposed to go do something, and you know what I'm saying? Like, or if you're trying to teach a specific, like, I don't know. I guess I'm trying to ask, like, how do you handle confusion, memory, and discipline with a child with a brain injury?
Okay, I'll do my best to answer that.
It's hard because I don't have a scenario right now, but I mean, I'm sure I've had them in the past. I just can't think right now. But I remember thinking, like, should I go there with this kiddo, or is he just is he flooded and it's not worth it, and just to let him rest? That kind of, like, when do you know? I guess I'm still learning it. My son's a year out, so. Okay.
Yeah, and I would say that as much as I've been talking about science tonight, there's probably as much an art as a science to that. And what we teach when we're teaching other professionals how to deal with crisis situations and folks who are in crisis and really revved up and things like that, is that when someone's really angry or emotional or something, what tends to happen is messages don't get in, that they're kind of in fight or flight mode, and really any talking at that point is not going to be effective.
But
So
what if they, sorry to interrupt, but just now that I'm thinking of something, like, let's say they say an inappropriate word, and because my son is in middle school, and he has already heard them before, even in elementary. So let's say they've learned even more so, especially as he was entering middle school after his brain injury, he was picking up and learning a lot. So that was really,
yeah.
so we get to deal with a whole new set of behaviors that probably wouldn't have otherwise happened, as a younger. But so he's picked up a lot, and his brain has relearned a lot. And in those are some of the insulting comments. So long story short, so if they're brain fatigue and then they pass a comment back at you that's inappropriate, do you handle it knowing that they're losing control? How would that, and sometimes I have to think how a teacher might handle it, or an outside, like a policeman, or I have to think about my child in society. He's 12.
Yeah.
They're not going to be like, oh, it's okay, sweetie, you have brain fatigue. But then I wish they would, but they may not know him. And I try to advocate, like have him self-advocate breaks, even teaching him that today, but it's difficult because he's only 12 and he now has a brain injuries.
Right. So I guess one suggestion is to kind of get back to the instrumentality of this. Like what is he trying to accomplish by doing that? Is he trying to get your attention? Is he trying to get you revved up, riled up, or whatever? And to kind of figure, it's hard to figure that out, but it's something.
It could be just anger and anxiety. It could be exhaustion and just losing self-control, dysregulation.
Yeah, I guess the first thing would be to make sure you don't reinforce it. That would sort of be one thing. Just it's, like I was sometimes, it's like, well, if I'm going to be miserable, everybody's going to be miserable. So I may as well just let out a few curse words, and sort of get the party started, and at least we could have everybody. Misery loves company, kind of thing. So kind of ignoring it, as best you can. And again, I know that it's hard to do that, especially if you worry down the road and you're looking forward to, what if he says this to the wrong teacher or to a police officer or something that it could be.
I do think he only keeps it in the home, but that's because this whole school year there's been no issues. It's in the home for sure, like where he's comfortable and stuff.
Yeah. And then, maybe a brief repeated message, just kind of like the Coke machine, is like, that's not appropriate. Let me know when you're ready to talk appropriately. And then on the flip side of that then is you need to reinforce the heck out of appropriate conversation. And the quicker he snaps back and is appropriate, then you kind of have to be all over that.
So even, we don't know where the damage was done or whatever. I have to still get an MRI even a year out. But let me ask you this. So what if, I always feel like in my heart, I'm like, what if there's damage here, there, wherever, and he just can't really help it because he is different than what he was. So I always wonder, like, how, like, I wonder, can he help it? So that's why I kind of am also like, do I teach it? Like, do you teach them if they can't help it? Or I don't know, like, it's confusing to me because I'm like, can he help it or not? Like, should I say this? Can he even can he comprehend it? Can he compute it? Can he understand it? Is it going to really message through to him?
Yeah. I guess the way I would, again, sitting here as calm as can be and not being in the moment when those things are going on, I guess the best way I would say to approach it is to assume, hear me out. This might be a little confusing. It is the brain injury. So, and if you want to translate that as can't help it, then that's fine. But then further, he can learn to help it. So I truly believe that no matter if somebody is still alive after a brain injury, they have more good functioning brain than they do damaged brain.
Okay, that's the answer I'm wondering.
Yeah, it's the brain injury that said the swear word, but there's still enough good brain in there to be able to compensate and learn new, more adaptive skills.
Just leave a lot of room for lots and lots of mistakes.
Yes.
A lot more than prior then. That would probably be, yeah, lower the expectation, or at least adjust the expectation.
Exactly.
Than before. So yeah, it's difficult, but yes, thank you.
You're welcome. Okay. So We'll have to take one more question. What is the balance when dealing with verbal or physical aggression between holding a child accountable for their actions and tying it to their brain injury? Oh, that's a terrific question. I think, and again, I'm thinking out loud, so bear with me here. I think you can do both. That it's sort of the principle is to criticize the behavior, not the person. And it's if you're going to be accountable, and we're going to have to figure out a way to manage that. That maybe in that moment with whatever was going on, you were frustrated or whatever, and didn't have the tool in your toolbox to manage the situation better. We're going to let you calm down, particularly if you're in that sort of flying off the handle, fight or flight kind of mode. But when you come down, when you're able to hear words again and talk, we're going to sit down and figure out how to get you to the Home Depot of coping mechanisms and get you something so that we have a better way of dealing with that in the future. So I guess it's a mix of doing both, and every situation is so very unique. But I think that's what you kind of have to. It is the brain injury, but we need to fix this. And again, in almost every case, there's enough functioning brain matter there to be able to come up with good coping skills to deal with it better in the future. But oftentimes, in the middle of when it's happening, especially if the person is really lit up, you're not going to have much of an effect right there in the moment, because what we teach folks in the rehabilitation setting is high emotions, high anger, whatever it might be, is a progressive loss of control. The angrier you are, the more out of control you are, that you're literally in fight or flight mode. The more you're in fight or flight mode, if any of y'all have ever, I'm sure in dealing with your child's injury, I've had no other time you have been where it's just flat out autopilot. You couldn't have a conscious thought. You're just acting, that it's everything. And that's what the individual is going through when they're super angry. There might be that tiny little 1/10 of the brain going, boy, oh boy, this is not a good idea. I shouldn't be saying these words. I shouldn't be doing this kind of stuff. But the other 90% of the brain that is completely in fight or flight mode is like, we're going. we can't hold this back. So you got to let the situation sort of de-escalate a little bit, and then deal with the behavior and try and come up with whatever the mechanism is to make it less likely. It's often very effective that if you can go into a situation prepared, saying, this might happen, this is what I'm going to do, that's always kind of a better way to function. Again, we do that when we're training our professionals. It's like, what's your button? What is it? Is it that you're overweight? Is that you don't like when people call you stupid? What is it? Imagine that happening, and what are you going to do? Now, in a calm moment, write a script, write a computer program to deal with that, so that when it happens, you could just launch that program. Sometimes that can be effective. So, again, I appreciate everybody's questions. I'm going to hand it back to Rhonda now.
Well, thank you all for being here, and thank you so much, Dr. Temple, for taking your time out to be with us tonight. So it's so good to see all of you, and just email me if you have any additional questions. I'll try to get answers, and we'll help you all have a good rest of your evening.
Y'all too. Y'all take care.
Bye-bye.
Bye-bye.